and do not intend to discuss any unapproved use of a product. So my name is Julie Emery, and I am the Pediatric Medical Home EPSDT Coordinator for the Bureau of Family Health, Office of Public Health, Louisiana Department of Health. And today we're going to spend some time talking about perinatal depression and screening in pediatrics, as well as a few valuable lessons learned from clinics that have been engaging in this work. I want to start this morning by grounding us in the prevalence and statistics surrounding perinatal mental health. This includes a range of disorders and symptoms, including but not limited to depression, anxiety, psychosis. These disorders and symptoms can occur during pregnancy and/or the postpartum period. And together, that period is often referred to as the perinatal period. These illnesses can be caused by a combination of biological, psychological, and social stressors, such as a lack of support, a family history, as well as previous experience with these disorders. Up to 1 in 5 women in the perinatal period will suffer from a mental health disorder, and unfortunately, less than 15% will receive treatment. Up to 56% of those living in poverty experience postpartum depression. And untreated maternal mental health disorders are estimated to have an annual economic cost of $14.2 billion, and more than 600,000 will suffer in the US annually. Also, the Gen Z population is more than twice as likely as boomers to suffer, and the rate of depression more than doubles in the Black population. This information is pulled from the Policy Center for Maternal Mental Health, but I also don't want family. Infants and young children of perinatally depressed mothers are more likely to have a difficult temperament, as well as cognitive and emotional delays. We know that perinatal depression has been linked to reduced sensitivity and responsiveness in caregiving, which can impact the important bonding time and attachment development for infants. Perinatal depression is linked to poor social, emotional, cognitive, language, motor, and adaptive behavior development in their children. And it's also linked to that increased occurrence of depression later on in children and adolescents. There are many organizations that have released briefs or statements supporting perinatal depression screening, including the American Academy of Pediatricians, the Center of Medicare and Medicaid Services, and the American Psychiatric Association, as well as many others. Specifically, the AAP provides a recommendation that screening should take place at the 1, 2, 4, and 6-month well-child visits, and emphasizes the importance of early identification and intervention for mothers with depression, and that helps mitigate the impact of parent-child interaction and social emotional development. In the 2022 legislation, Act 188 was passed to state that a pediatric provider shall screen the caregiver for postpartum depression, and then also provide those referrals if needed. Pediatric providers are the first line providers with the greatest opportunity to recognize and respond to potential concerns due to multiple encounters of well child visits during the infant's first year of life. Pediatricians and pediatric providers are dyad focused. They have an overall view and surveillance of the child with multiple touch points, and typically they're family centered with that strong relationship and connection to the community. So it really makes it an optimal space to not only care for those infants, those babies, but also make sure their families and that environment that they are growing and developing in are healthy as well. Building from what we know about perinatal depression and care in pediatric clinics, the Louisiana Perinatal Quality Collaborative launched a 12-month learning collaborative pilot to test implementation and referral strategies in 4 clinics across the state utilizing quality improvement science. The pilot aim was to achieve and maintain an 85% screening rate among caregivers using a validated tool at the 1, 2, 4, and 6-month well child visit. And I'm happy to report that we ended the pilot with a 98% screening rate as well as a 100% referral rate. For those of you who are unfamiliar with the LAPQC, this collaborative is housed under the Bureau of Family Health and seeks to promote safe, equitable, and dignified patient-centered care for all people who give birth and their infants in Louisiana, and they lead several action-based initiatives. Now we're going to discuss some of the lesson learned or shifts and adjustments that some of the clinics made when participating in the Learning Collaborative. Throughout the 12-month cycle, we asked clinics to collect data, recording the screening results, referrals, and utilizations of the referrals, and recording these activities and then zooming out and reviewing with the team highlighted some opportunities for improvement over that 12-month course. So for one of our clinics, they noticed that while using the PHQ-2, that there was almost a 0% positive rate. And when comparing this number to the national rate, as well as thinking about their conversations with families and maybe how they answered some general questions, they were concerned that this screener was not capturing the population of the families that they serve. And so they used a number of plan, do, study, act cycles, also referred to as PDSAs, to test the use of the Edinburgh postnatal scale that screens for both depression and anxiety. According to their data and both staff and family feedback, they were able to identify a larger number of caregivers who had concerns or were at risk and link them to the appropriate resources. So they, through collecting that data, through the quality improvement science, they made a shift of the screener to make sure that it best fits their population. Other things that we tested throughout the pilot, several of our clinics tested scripted phrases to use at various points of the screening process. They thought about when and where the screening was taking place, how it was, when it was being completed, where it was going to be completed, and how it was being introduced. They thought about who was handing the screening to the caregiver. Was there interaction at that point, or was it passive and scripting needed to be included maybe on top of the screening instead of a verbal exchange? A few examples would be to include a few sentences that ensure caregivers that each and every caregiver is receiving the screening at these particular well child visits. because we care about both you and your child and want to make sure that you're well. We certainly don't want any caregivers to feel as though they have been targeted for this screening or a decision was made to specifically give it to them. But however, the scripting that is provided lets them know that this is a standardized screening because it is best for you and your family. And so several of those scripting for the introduction was tested within our clinics. Another example is when the screen may not be technically positive, but there is some risk identified. So providers found it helpful to have some prepared phrasing to offer resources as that proactive approach. Another big lesson learned is how the screening is administered to ensure that no one is being missed and also that it feels safe from the family's perspective. Most of the clinics that we have supported are doing paper versions of the screening, and many times that sheet was not returned or it was lost in other paperwork, and the providers had difficulty kind of establishing that fluid pattern in their visit. So several clinics shifted to offer the screening on a pink sheet, so copying it on a pink copy paper versus a white. And this helped provide a visual cue for providers as well as it softened the language for families. And so instead of asking, can I see your pink sheet? Or instead of asking, I've looked at your depression screening, or can I see your depression screening, especially if there's other people in the room, providers were able to say, have you submitted your pink sheet? Have you turned in your pink sheet? Let's review your pink sheet. So it really helped kind of soften that language in that conversation. Several PDSAs were conducted to adjust the pink sheet to include everything that the providers needed for a successful workflow. So let's look at one of the pink sheets. This pink sheet example is provided to us by Our Lady of the Angels Pediatric Clinics, and they used several PDSA cycles over the course of several months to adjust their sheet to best fit their clinic workflow. You can see at the top they've included the time frame of what well-child visit that they are conducting this screening. They also included that standardized scripting that we just spoke about to make sure that it has appropriate language and that it's standardized for all caregivers receiving the screening. And then they also added caregivers details, and this allowed them that if it was positive or if a risk was identified and they needed to make a warm handoff or referral, they had that caregiver information, that OB information, everything right there on the sheet. So additional questions weren't needed. On their sheet, they have the PHQ-2 at the bottom. And then it lets families know if the particular score is added up, then they ask them to turn it over, and the Edinburgh's on the back. This section that you see is at the bottom of the back, so it's underneath the Edinburgh. And this allows for the clinic to track the referrals was made. Was there a warm handoff? Did they help that caregiver reach the referral needed? Give the OBs a little phone call and let them know what's happening, or another provider that they're choosing to see. And then the referral utilization, a referral is only as good as the utilization, right? So it was helpful for this clinic to go back and make sure, or to follow up at that next well child visit. Were you able to get in touch with your provider? Were you able to access counseling, just to make sure that we're following up and we're making sure that that connection is made when we've provided that referral. So, also coming from Angels is a chart review sheet that they developed, and this is helping to find out if they've looked at their data and maybe they've reached 80% of screening, or they know that they have missed some caregivers and they wanted to dig in and find out why. Were there any patterns and why we've missed specific screenings? So they looked at what type of visit. Was it scheduled as a 1 month, 2 month, 4 months, 6 months well child visit, or maybe it was scheduled as a weight check. And so it should have been a well child visit, and that's why it was missed. Was there additional training, that there was a pattern of a particular rooming nurse or provider or front desk staff that we needed to do some additional training with? So that kind of helped them determine what was happening and why the screening wasn't taking place for those that are missed. And then the same thing with positive screenings. Was there referrals that were missed? Were there utilizations that were missed? And so they developed this system and shared the load between providers who had access to those charts to do the review, and just checked it every couple months so they can really determine, why are we missing families and how can we change that? How can we do better? So a few other additional notes or things that were shifted and learned throughout working with these clinics is, particularly in one of our larger or more rural FQHCs, they recognized that there was additional needs for families. When they began doing the caregiver depression screenings, um, they were able, through conversation, to see that big picture and see there's a lot going on with families that they wanted to be able to support, which also supports obviously the health and development and growth of the child in their care. And so they began testing and incorporating the barriers to health screening, and they chose the SEEK, which is the safe environment for every kid, that ask about food insecurities. It asks about safety, and things just to really support that environment. And doing so, of course, we have to be ready to respond. And so they spent a lot of time connecting with local nonprofits and building a list of community resources that support that SEEK screening, making sure that they had the updated list, assigning who was going to be responsible in their clinic to making sure that those resources are vetted and stay up to date. And in doing that, and this was really a full 12-month process to test several different things within this process. They determined that at the time that they did the SEEK screening, they needed to add additional time to the visit, because it does open a lot of conversation, additional conversations and needs that needed to be met, that they needed to discuss. And they also discovered that there was a hardship on some of the staff that were having these conversations, that there was a bit of some secondary trauma that was taking place when getting to know these families at a deeper level and understanding their needs at a different level. That it was having an effect on the staff, and so there needed to be some wellness and some safe, guardrails, if you will, put into place for the staff to support them as well, so that they can fully support the families that they serve. A few other things, each of our clinics went through creating a clinic algorithm of how they responded. Each was unique to their own clinic. There are some standardized algorithms for the screenings, but what makes sense to each of the clinic per score. And so if they're is a minimal risk identified, if there are proactive approaches, what is the standardized resources that you give for every family that may not show a concern at the 1 month. However, we also know that that does not mean that there won't be a concern at the 2, 4, 6. And so creating that algorithm of what support resources that you are going to support caregivers with initially, and then specifically that referral utilization. You give that referral, then what happens next? Who follows up? How do you follow up? Is there a note in the chart to let someone know? Is there a note on that written sheet that says a nurse will follow up after a week? So finding what algorithm really fits for your clinic and what helps standardize that workflow so that it stays consistent. We also found that it is imperative to include all staff, including frontline staff, on education and training on perinatal depression and screening. We want everyone in the clinic to be aware of this need and what caregivers may be facing, and how our language and how we support, how we normalize screening can be impacted at all points of the visit. We have clinics that incorporated a morning huddle. This may be something that you already do for various reasons, but that was really helpful just to check in to make sure that we knew the needs of the patients that and their families that were being seen that day, and we were all on the same page. And then finally, including all caregivers. We had a great story from one of our clinics that the mom had come in for the initial 1-2 month visit and had tested positive, and were given resources and connected to those resources. And so in the next visit, the 4-month visit, both mom and dad came in, and she submitted her pink sheet, and the provider looks to see, okay, well, we're still struggling, and it was ready to have that conversation. If you connected to the referral, and then determined that it was actually the father that completed that screening, and he was struggling as well. And the neat thing that we learned from this is that this clinic had standardized and normalized these screenings happening in the well child visit, so that they knew that by coming to this visit that he could be screened as well and be referred and have that same type of care to get connected to the resources. So it's really important to not just centralize your focus on that birthing person, but think about all of the caregivers that also are at risk from suffering from anxiety and depression. We leaned on several different supports. This is not an exhaustive list. This is just a few things that you can look into and support your clinic. Of course, our provider-to-provider consultation line. We have a quick guide. If you are in a clinic that has not begun the work at all, there's a quick guide to help you get started. Our developmental screening tool, and then Postpartum Support International is also a big support. So thinking about changes you may wish to make in your practice, if you are not already implementing the perinatal depression screening using quality improvement methods, we have, like I said, a variety of supports to do that. If you have, review those current practices and determine if there's any components that you need additional support. If you want to test any of the things that we talked about today and see if it works best in your clinic. And then really commit to that ongoing training for staff around perinatal depression, around the risk, around normalizing those screenings within your pediatric practice, so that we can ensure that not only that child in our care is healthy, but the environment and the family as well. So I'm going to pause here, and we have a couple minutes left to see if anyone has any questions. I believe that with the webinar feature, you put those in the Q&A.
Yes, they can. I'll wait just a couple seconds to see if there are any. Right now, we don't have any yet, but let's see if they're typing and wait a second. And just while you all are typing or entering your questions in the webinar chat or the Q&A section, I just wanted to remind everybody that if you are a social worker, nurse practitioner, or physician, and you would like to receive CE or CME credit for today's attendance, please make sure to attend the webinar in full and complete the evaluation at the conclusion of the session. Julie, I don't see any questions in either of the platforms. So I will conclude the webinar today. Thank you all so much for attending. And of course, if you have any questions or would like to receive any additional support from Julie, please email her at the email on the screen. Thank you all so much for attending. Have a wonderful day.